Right, so this is 2 minutes past 1. I think what I'll do is I'll make a gentle start to today's webinar. So welcome everyone to this afternoon's webinar on evaluation of complex and multi-component interventions. My name is Olivia Wu. I'm the director of the NIHR Complex Review Support Unit. So for those of you who are not familiar with the Complex Review Support Unit, we are funded by the NIHR, and our job is to support NIHR-funded reviews and primarily Cochrane reviews in terms of providing methodological support. We do this by providing one-to-one consultations and also group training, a bit like what we're doing today. It's really good to see some of the reviewers that we've worked with previously on this webinar. So it's good to see you guys again. Today's webinar has been jointly developed between our unit and the Cochrane Public Health and Health Systems Network. And the idea originated from a lot of our unit's support work. And actually, you'll hear about a couple of examples later on in this webinar. I'm sure we all know evidence synthesis methodologies is evolving at a very fast pace. We're much better and also much more ambitious in our efforts to maximize the value of existing evidence to support decision-making. And today we're going to focus on complex and multiple component interventions. Intervention complexity is one of the new chapters that's been introduced in the latest update of the Cochrane Handbook. And the chapter talks about the value of understanding intervention complexity. It talks about considering the number of components within interventions. It talks about considering the interactions between components or between the components of the interventions or between the interventions and its context or both. And it also talks about considering the wider system within interventions will be placed. So this webinar very much aligns with these underlying principles. We're very lucky today to have speakers from both the unit and also friends of the unit throughout the webinar. We'll start off with a talk from Alicia Smith, who's Research Associate at University of Leicester, who's also a member of this Complex Review Support Unit. Alicia has done a review on synthesis methods that have been used in NICE public health guidance. So that's a really, really good place to start for us to have a understanding of what methodologies have been used in synthesizing evidence for these guidelines. And then Professor Paul Gardner, who is from the who's coordinator from the Center of Evidence Synthesis for Global Health and also for the Cochrane Infectious Disease Group, and also director of the Research Evidence and Development Initiative. I think many of you know Paul already, and he's going to talk about the challenges in identifying and describing components in complex interventions. And after that, Debbie Caldwell, who's Associate Professor in Epidemiology and Public Health and at University of Bristol, we're talking about lumping and splitting of components in meta-analysis of complex interventions. And then Suzanne Freeman, who's from University of Leicester and also a member of CRSU, will talk about component analysis. One of the approaches that we can use to synthesizing multi-component interventions. And then after that, we're going to share with you some of the examples that we've worked with Cochrane reviewers. So Dr. Terry Quinn and Jenny Burton, both from the University of Glasgow and also the Complex Review Support Unit, will talk about an example on delirium prevention. Professor Alex Sutton from the University of Leicester, again, one of the CRSU members, will talk about an example of smoking cessation. So this is how we structured the afternoon, and I hope you'll find it interesting and useful, especially for those of you who are currently doing a complex review involving complex interventions. So just a couple of housekeeping announcements before I pass on to my speakers. All the webinar will be recorded, so you'll be able to access the recordings again after today from the Complex Review Support Unit's website. We also would like to invite you to share with us your comments and also any questions that you might have along the way using the Q&A function. So what I'll do is I will be looking after the questions, and during the Q&A sessions that we've got planned, we will address those questions and comments that you'll have posted. So what I would say is don't be shy in sharing your thoughts, and we really would like to have good interaction with you. It's very difficult on Zoom. Ideally, we would have liked to do this face-to-face and somewhere nice, but this is not possible for today. So so please do use the Q&A function so that we can have a bit of a dialogue with you as well. Okay, so so I think that's all I'm going to say for now, and I will hand over to Alicia, who will be giving us the first talk today on synthesis methods used in recent NICE public health guidance. Alicia.
Thanks, Olivia. Just share my screen. Is that okay? Can you see my screen?
Yeah. Yes, looks good, thanks.
Hello, everyone. As Olivia said, my name is Alicia Smith, and I'm a research assistant at the University of Leicester. So this talk investigates the evidence synthesis methods used in NICE public health guidelines. And talks later today will explain the methods, but this talk demonstrates the slow uptake of meta-analysis methods in public health and the opportunities available for implementing them in public health. So in order to make well-informed decisions and provide the best guidance in healthcare policy, it's essential to have a clear framework for synthesizing good quality evidence on the effectiveness and cost effectiveness of health interventions. There are a broad range of methods available for synthesizing evidence from systematic review, including qualitative synthesis methods, such as narrative reviews, and quantitative methods, such as meta-analysis. Quantitative methods are widely used in the synthesis of evidence in clinical trials, where the evidence base usually consists of randomized controlled trials, and the interventions are well defined. However, they are not used as often in public health due to the many challenges that are faced in synthesizing public health interventions. For example, there is often methodological heterogeneity due to the variety of study designs used within public health topics. Often the interventions are poorly described, and this means that there's variation within the groups. There are usually a wide range of outcomes, and sometimes surrogate outcomes are used in the place of final outcomes. And often the interventions are complex, which could mean that they are implemented in a variety of settings and populations using a range of modalities. But in this presentation, I refer to complex interventions as interventions that are made up of multiple interacting components, which is the focus of today's webinar. So given that guidance and methods for synthesizing public health interventions has improved, we wanted to see if the use of methods has changed over time. So in 2014, Achana et al. Published a review of the methods used in NICE public health guidelines and found that meta-analysis methods were not being used to synthesize effectiveness evidence. We updated this review to find out whether this had changed since the previous review, and to find out what methods are now being used and what are the reasons given when meta-analysis methods are not being used to synthesize the evidence. So this review looked at NICE guidelines. So this slide gives a bit of background into NICE. So NICE was established in 1999 as a health authority to provide recommendations based on effectiveness and cost effectiveness to ensure the transparent process of allocating NHS resources. The remit for NICE guideline production was extended to public health in 2006. And also in 2006, NICE published a manual to help develop NICE guidelines and provide advice. And although the NICE manual provides recommendations across all topics that are covered by NICE, there is no guidance in the manual that focuses specifically on public health. So this review was based on a previous review by Achana et al. In 2014, which explored the methodology in NICE public health guidelines published between 2006 and 2012. The authors conducted a systematic review of methods used to synthesize quantitative effectiveness evidence within NICE public health guidelines. They found that only 23% of the NICE public health guidelines used a pairwise meta-analysis as part of the effectiveness review, and the remainder used a narrative review or no synthesis of evidence at all. The authors argued that despite significant advances in the methodology of evidence synthesis, the uptake of methods in public health intervention evaluation is lower than other fields, including clinical treatment evaluation. The paper concluded that more sophisticated methods in evidence synthesis should be considered to aid in decision-making in the public health context. So for this systematic review update of NICE public health guidelines, we conducted the search through the NICE website and filtered by public health guidelines. Some of the guidelines had been updated with new documents or merged, so the search criteria included all documents that had been published from inception until August 2019. We excluded qualitative reviews, field reports, expert opinions, and other supporting documents, and we extracted data on type of review, design of the included primary studies, outcomes, and details of synthesis methods. Further details were on the interventions were recorded. For example, whether interventions were lumped together for a pairwise comparison, whether interventions were complex and details on the components. And we also assessed for potential use of complex intervention evidence synthesis methodology. So this is a summary flow diagram describing the literature search. There were 67 NICE public health guidelines available on the NICE website. Since the previous review, 22 guidelines had not been updated, and the results from the previous review were used for comparison to the 45 guidelines that were either newly published or updated. The 45 guidelines consisted of 508 documents that were assessed for relevance, and 2 of the NICE public health guidelines did not include any report that met the inclusion criteria. Finally, 167 documents from 43 NICE public health guidelines were systematic reviews of quantitative effectiveness, cost effectiveness, or decision model reports. This table compares the results of the update to the original review and shows that the types of reviews and evidence synthesis methodologies remain largely unchanged since 2012. The proportion of guidelines that only contain narrative reviews to synthesize effectiveness or cost effectiveness has reduced from 74% to 60%, and the proportion that included a meta-analysis has increased from 23% to 31%. So these changes demonstrate that the use of meta-analysis in NICE guidelines has increased but remains low. Only one NICE guideline contained a review that implemented a network meta-analysis to synthesize the effectiveness of multiple interventions, and this was the same guideline that used a network meta-analysis in the original review and had been updated. The proportion of guidelines with reviews that only included evidence from randomized controlled trials and assessed the quality of individual studies remained similar to the original review. So within the original review, there were 9 NICE guidelines that had 10 reports that presented a meta-analysis. Within this updated review, there were 24 reports from 14 guidelines that included a meta-analysis. So this table compares the characteristics of the meta-analyses used in the evidence synthesis of NICE public health intervention guidelines to the original review by Achana et al. So overall, the characteristics in the updated review have not changed very much from those in the original review. But lumping of interventions still appears to be quite common in 50% of the reports in the updated review. The frequency of reviews and guidelines that use meta-analytic methods were plotted against year of publication. The number of meta-analyses is quite variable, but there is some suggestion that the number of meta-analyses is increasing, particularly in 2018. An evaluation of the interventions reported in the reviews concluded that 50% of reviews had lumped multiple interventions into a control versus intervention pairwise meta-analysis. Some examples of this are given in the table, where multiple interventions in the right-hand column were lumped together. Many reviews also performed a series of pairwise meta-analyses. And in these cases, a network meta-analysis could have been used to compare the effectiveness of multiple interventions. We also extracted data on whether interventions in the reports that used meta-analysis were made up of intervention components, and therefore whether there was potential for the use of more sophisticated methods, such as component network meta-analysis. We found that 46% of the reviews evaluated interventions that were made up of multiple components. And a few examples are shown in this table. For example, in the physical activity exercise referral schemes guideline, interventions were made up of a combination of counselling, written materials, and supervised exercise training. The 143 reviews of effectiveness and cost effectiveness that did not use a meta-analysis method to synthesize the quantitative effectiveness evidence was searched for reasons behind this decision. 49% of the reports did not give a reason for not synthesizing the data using a meta-analysis, and 164 reasons were reported. Out of the remaining reviews, multiple reasons for not using meta-analysis were given. 37% of the reviews reported at least one reason due to heterogeneity. 3% of the reviews reported that meta-analysis was not applicable or feasible. 1% reported that they were following NICE guidelines, and 3% reported that there were a lack of studies. So this review found that the proportion of NICE guidelines containing effectiveness evidence summarized using a meta-analysis has increased since the previous review, but remains low. The majority of reviews presented only narrative summaries. Out of the guidelines that used meta-analysis, only one used network meta-analysis and the rest used pairwise meta-analysis, often lumping different interventions together. And although only the simplest methods are currently being used, this review has demonstrated that there are cases where more sophisticated methods could be utilised within public health topics. A high proportion of NICE guideline reports did not provide a reason for not using a meta-analysis, and the most common reason was heterogeneity. And this is common in public health due to differences in study design, interventions, populations, and outcomes. But a common misconception is that the presence of heterogeneity implies that a meta-analysis cannot be used. So we concluded that despite heterogeneity in public health topics, meta-analytic methods can be used to investigate the sources of heterogeneity. Although the interpretation of the results should be cautious, quantitative synthesis methods provide a stronger basis for making decisions than narrative accounts, because they explicitly quantify the heterogeneity and seek to explain it where possible. That's it.
Thank you, Alicia. And I think your conclusion also speaks very nicely to one comment that we've already got about heterogeneity. What do you do if you can't quantitatively synthesize the evidence? And I guess this is the purpose of one of the purpose of today's workshop, I guess, is to really try and understand how far we can go with a quantitative analysis in the presence of heterogeneity. And I think, as Alicia has highlighted, that perhaps there are occasions when we're too quick to dismiss the potential of a quantitative method. So it'd be good to hear your views, and any questions for Alicia, please post it in the Q&A, and we will address that at the Q&A session. But before that, I'm going to introduce our friends of CRSU, Professor Paul Gardner, who's going to dig a bit deeper into the components of complex interventions, and help us think a little bit more about heterogeneity and in this context. So, Paul, I'll hand over to you.
Thank you. Screen is there, and you can hear me okay?
Yep, all good.
And the wine hasn't arrived, but I think we'll find a way around that. I'm quite honoured actually to be presenting to you, and thank you, because I work in the Cochrane Infectious Diseases group, and we normally are looking at new anti-malarial drugs. One drug better than another drug, for example. But we do dabble with complex interventions, and this actually started some years ago with this headline in a newspaper when Nakajima, the then Director General of WHO, announced that they had an advance in the treatment of tuberculosis that was probably as important as the discovery of penicillin. It was going to save millions of lives. And Nakajima, if people don't remember, I actually remember was staying in a Thai hotel at one stage for a conference, and because he's the Director General of WHO, they put him in the executive suite, which was on the 10th floor, and he found out that there were some of his staff were on the 15th floor, and being a hierarchical man, he was somewhat upset, and so had to be moved upstairs. So this was how WHO was operating at the time. Anyway, so what happened was that somebody you might recognize, Ian Chalmers, this was taken at the weekend, sent me a fax of this and said, Paul, you're just setting up this Cochrane Infectious Diseases group. Do you think he's got this right? And so we embarked on is this directly observed therapy right? Is it going to save hundreds of lives? And that was the strapline of WHO. Directly observing patients taking their treatment is going to save all these lives. And the review that we carried out with Jimmy Volmink included in the discussion that there were no randomized controlled trials in this area. There were lots of observational studies, and all of these trials had accompanying interventions, improving access to services, increased availability of drugs, contact tracing, and so forth, that were to account for the assumed effects. And actually, over the subsequent 2 years or so, we lobbied WHO, and they did actually clarify that directly observed therapy, short course, meant all of these things: political commitment, laboratory services, drug supply improvement, better support reporting, and a classic email from them that it may or may not include direct observation of treatment. Anybody that's in the audience, if you get an email like this, copy it, photograph it. I wish I still had it. Anyway. So this is an example of the World Health Organization complex intervention transformer, where they take a complex intervention such as directly observed therapy, when they actually are talking about politics, money, and improved health systems, put it into this box and turn it into a simple strapline, which is watch people taking their drugs. And this misleads and does damage and doesn't help. So we went back over the trials and looked at all the observational trials. And this is a paper published in The Lancet, which doesn't include any effectiveness data at all. It simply describes the intervention of directly observed therapy. And the two analyses that may be of interest are each of the references down here, where we look to see whether the paper actually reported issues that were WHO claimed were part of directly observed therapy: political equipment, laboratory improvement, direct observation, drug supply and reporting systems. And it was very mixed apart from direct observation, obviously. And then we looked at the content of these studies, and they were extraordinary. I mean, they moved from Nepal, Somalia to New York, drug addicts in New York. I mean, a real mixed bunch. And the interventions we split. So this descriptive study described it between patient, staff, and others. But some of the interventions included relaxed atmosphere, birthday parties, free food, clothing, books, incarceration if you didn't take drugs, free food and cigarettes if you did. So it was quite revealing anyway. So and in fact, the Cochrane review now does have these sort of headings to try and describe the interventions. And the only randomized controlled trial that's been conducted that shows a small effect, the rest show no difference between self-treatment and direct observation, is one here where you can see on the directly observed group on the left, these on the left, they are seen daily by a clinic health worker or a community health worker, whereas a self-administered therapy, they're only seen once a month. And there's a very small increase in cure in this group. And, you know, just the intensity of the observation is very different. So, you know, this is not unusual in WHO. There was we got involved in the worm war, in debates about soil transmitted helminths, the so-called worm wars. We were actually proud to be trending on Twitter at one stage on this, where it's discussing whether giving children deworming soil transmitted helminth drugs at home at school improves their nutrition, improves their attendance at school, and improves their performance when they become adults in terms of work and productivity. The incredibly pretentious event called the Copenhagen Consensus, where Nobel Prize winners come together to decide how every few years, what's the best way to advance global welfare. And they considered one study of deworming and decided that this was how they would spend their 75 billion if they had it. Again, and then if you look at the review of about 40 studies, the only study that shows a small effect on attendance at school is this one at the bottom, the Miguel study. And this wasn't just deworming, it was preventive education through regular public health lectures, wall charts, training of teachers, health education, wearing extra money was also going into these schools. So the fact that the children attendance increased was nothing to do with the deworming. It was to do probably with the activity going in to the schools. And again, so there we have their complex intervention transformer taking health promotion, deworming, complex intervention into a single one, which is then promoted. The deworm the world promoted treatment of the whole of India with deworming medicines on the back of this evidence. So it's very important we get this right. So really the last example is a more recent example of rapid initiation of antiretroviral treatment for people living with HIV. One of the problems with antiretroviral treatment starting in countries of Africa is that people get tested, and then by the time they get lost between being tested and treatment being started. They just vanish. And there's lots of discussions about linkage of care and how you maintain this linkage. And in that period, you may well want to get people orientated to the idea that they're going to be on treatments for the rest of their lives. But one fix is actually, as soon as you test positive, to go straight on to antiretrovirals that day. So this was tested, this was promoted by, was considered by WHO, number of very large trials done. And when we did the review, we were very careful to delineate carefully the interventions that were there. So in the Cochrane review, we tried to describe what accompanied this starting of the medicine on this day. And obviously there was lots of interventions, opinion leader training, receptionists that were trained, new testing facilities were brought in, mobile phone visits and so on. So we described this at individual health system level, dividing that between health providers and health structures, just to understand what these interventions were. And in fact, the lead author of them described them here in this way, which I'm going to let you just look at, and I'll be back in a minute. So you can see all the different inputs that were described, very, very complex. So what happened was that this was passed by the WHO, and actually when it was rolled out in practice, the performance was nowhere near as good. So because all these complex interventions were not included, and people were just being given drugs at the time of diagnosis. So does this mean then we need an ingredients approach in Cochrane reviews? Well, I think it probably does. And developing these descriptions takes a bit of time. You kind of need to get into the literature, perhaps have a theory of change, work out where the components might lie, and then try out different ways of how you might describe them. And I think what we have to be careful of, though, in some of the grouping in Cochrane reviews, for example, looking at one or more interventions versus no interventions, is kind of losing the sense of what's happening in the individual studies. And as Sandy Oliver, a good friend, said, it's all rule-based epistemology and no thoughtful ontology. We don't know what we are studying. So there is a risk in Cochrane of just following the rules of what we have to do around methods, but not actually understanding the content of the care and how it's being delivered. I think this is where qualitative approaches may help. And one of the things that we noted was that we've been doing adherence reviews for many years. And they all show, particularly in tuberculosis, they all show slight improvements in adherence, tiny improvements quite often of direct observation, of health education, of incentives and so on. So we thought, well, let's get into patients' heads with a qualitative evidence synthesis, and looked at this in relation to antiretrovirals in low and middle income countries. And suddenly there's this wealth of literature, absolute ton of literature out there, and understanding what it's like to have HIV and beyond treatment in these circumstances, the poverty, the competing priorities, the difficulty within families of continuing to take these drugs, and the health system, which can be uninviting, not always, but can be punishing. There was some studies where at an HIV antiretroviral clinic, patients were told, we're all queuing up outside. The health workers came outside and said, all the sex workers go to the back and everybody else come forward. So, I mean, it was just extraordinary how health systems push people away. So we found this really interesting, although I'm not sure how it directly helps with interventions. But I think probably what it does is the qualitative research should feed into the planning of the interventions. At the moment, WHO is using qualitative research just to decide whether an intervention is acceptable towards the end. But actually, that qualitative evidence synthesis was used to help plan a service to support re-engagement with care, which I think is really, really important and an important approach here. And Melissa and people that I'm working with here have looked at mass drug administration for filariasis. Now, this is really a fascinating area. I mean, mass drug administration has been used by colonial administrations and others since the 1940s for malaria, for worm programs, for also onchocerciasis, many diseases. But then when you actually look at the qualitative literature, you can't work out why people ever bother to comply. They are associated with colonial powers, they're associated with suffering, and they can be that many of them have not been embedded in their communities properly, and this is an important component of whether they're effective or not. So that's it. I just thought all I wanted to do today was to say that we need thoughtful, structured approaches to describe complex interventions, and they often need to be bespoke. You need to think about the intervention, perhaps go through the papers carefully beforehand and work out what the interventions are. Often the effects and heterogeneity can be explained by the core components and co-interventions. At the moment, WHO is using qualitative evidence synthesis really as an adjunct to its linear planning process, to its guidelines, and that QES is underused in designing, refining, and implementing complex interventions. So thanks to FCDO for funding us and to all the staff and partners that I work with.
Thanks, Paul. Thanks for such an interesting talk with lots of really fantastic examples. I must say, I do remember following the deworming debate, and it was very well covered by the lay press. So I do remember following those discussions.
I've lost my sound.
Oh, can you still hear us? No? Paul, can you hear us? No, okay. Well, we can hear him. And right, so in the meantime, we are slightly ahead at the moment, but it would be good to use this opportunity to chat with everyone, with all the attendees. It's really good. I can see we've got 47 attendees so far. And if you've got any comments or any questions, this is a good opportunity for us to have a chat. So Jorian has already posted comments on the issue of heterogeneity, and so it is very common, and I think Alicia has highlighted that in the presence of high unexplained heterogeneity, then a quantitative synthesis is not appropriate, and then what should we do? And Paul has covered, has talked about using qualitative methods, and I'm really pleased that he's talked about that. And I know our program today is very much geared towards quantitative synthesis, but with non-quantitative synthesis, I know there are lots of different approaches, but it's beyond the scope of this afternoon. So one of the comments is, they've presented forest plots, but they haven't pooled the treatment effect. But then I guess it's the balance. You're striking a balance between providing a lot of information and against trying to have a clear message from your overall review. So I guess that's quite challenging. So maybe I can start with asking just a couple of questions, Paul. As you were losing sound, I was just saying I remember following the debate of the deworming example, and it was very widely covered in the lay press. I mean, you showed that clip of the BBC More or Less program, and I definitely remember listening to that. And so. So what, how would you approach it? How would you do this differently? I mean, is this, I guess some people might argue, that's just the nature of these kind of reviews. It's so heterogeneous. There's so many components to it. So interpretation can be quite complex. So, what would your advice be when you're approaching something like that?
Well, I think you have to describe the intervention carefully, and that is often what is not happening. It's basic stuff. All these co-interventions are often the things that are explaining the effects, and the problem is that the policymakers aren't really interested in that. They just want a headline. They want something that appears to work, and then they just implement it, and it goes ahead. And it's a big problem anyway with trials, that you have these effects that appear in trials, but it's magnified here. So I think it's so important that we describe these interventions. And in Cochrane, it doesn't always happen. I mean, having absolutely dreadful tables functions doesn't help, because you really do need to get into mapping out what the interventions are to help the reader understand what's going on, so that we don't sophisticated analysis and meta-analysis. All of that is fine. You can see whether the intervention generally works most of the time or some of the time. But being absolutely clear so that policymakers know all the inputs that go in the original trials. And I really do think we haven't spent enough time, and maybe others have, but in trying to group the interventions, look at different ways of classifying them, and then pushing that back onto the trialists to describe the health systems, the training, the different categories of things that are happening in these complex interventions. Because just because they've got a label of directly observed therapy doesn't mean anything. It's all the other things that are happening that we need to know about.
So one thing that you mentioned, which really strikes a chord with me, the rule-based approach, you called it, and that really hinders the way that we really think about and try and interpret the evidence in front of us, and I wonder whether this is a challenge not just only for public health reviews, but just evidence synthesis in general. That I think fundamentally people really like the idea of having very clear rules and checklists, and they don't really like to make judgments. But evidence synthesis is really based on judgments, and it is a wider issue beyond public health interventions, isn't it?
Yeah, I utterly agree, Olivia. And I mean, there were no rules, so Cochrane come along, generate some rules, but keep on generating rules, and the handbook keeps getting bigger and bigger and bigger, and everybody thinks that you get to the answer by following the rules, but actually you get to the answer by breaking the rules or bending the rules or doing something that is thoughtful, and that we and following process. I utterly agree that we should follow a rigorous process, but we should also do it in a thoughtful way with these interventions, and tweak the reviews in different ways, and pull in qualitative information where it makes sense, and just characterizing, for example, mental health interventions. I mean, there's so many components to that, including the relationship between the provider and the patient, the class, the length of it. It's all of these things, and they're terribly important to understand in understanding why things work or they don't work. And there's no rule that would tell you that the Thai study, the Northern Thai study from directly observed therapy, is more effective because there's more going on in the intervention group than in the control group. But when you then map it out, and then that's interpretation. These people just had more contact with care, and that's what's going on.
Yeah, I absolutely agree. So we have a question here quite asking, what about evidence maps? The use of evidence maps to display the link between components of interventions and effects. Is that a helpful tool?
Pass. I mean, I think anything that, yes, there's lots of maps in my head at the moment. So I think the diagram that I showed to you that went to the WHO committee with all the dots in it was quite useful. And yes, I think using, I don't know quite what you mean by evidence maps, but I certainly use it looking at all the components in the intervention, perhaps grouped together. Is even with radio dots, is a useful approach to describing interventions. But qualitative evaluation of the interventions are the nature of the provider. Government services and NGO providers may have the same sort of radio dots, but actually the care may be delivered in a very different way, which will influence how people behave. So yes, I think they would be useful. We need more different ways of describing the interventions in different ways, not getting too hung up on totally linking a component to an outcome, because that's the other thing that people do, say, oh, well, if you've got that, then that happens. No, you've got this package of things over here, and then the aggregate effect is over here. So it might be that one of them is important, but often it's the whole package and the way it's delivered.
Yeah. Okay, so we'll take another question, and then I might go to some of our fellow panelists and see if they have any additional comments to what we're discussing. So this is a question: do you think that sometimes reviewers are not given enough time, or do not take enough time to actually perform the synthesis well, or to develop the protocols well at the start of the process?
So. I think with the mapping of the interventions or the describing the interventions, you actually have to get into the literature. You have to have some idea about what programs are. So if you're looking at dengue control, you know that dengue control can be top down from the government spraying, and then there'll be community. So you can already perhaps predict in the protocol that you might describe it in terms of what's happening at community level, what's happening at district level, and what's happening centrally. But you really, and so you do need a conceptual frame on which to then start looking at the interventions. But then when you've got the papers in front of you and people that are familiar with these programs, then you can start a sort of constructive dare I say, imaginative approach to sort of start describing them in a way that makes sense to allow you to compare between interventions, or to at least look at how they are different from each other. So I think part of it will come from the protocol, but part of it needs the team of people, including senior and junior people, so that it isn't all dumped on junior people to get on with it, that people with field experience can look at it, and people that have organized programs can understand what might be the levers. And you might even have a theoretical framework in the background as well that you either prove or disprove as you go forward.
Yeah, and I think related to that, something that I truly believe in, and I think we've actually, as a unit, we've given talks on this, is actually thinking about the question very carefully at the start. No, I think even, you know, by the time you think about protocol is already a bit too far down the line. And I think thinking about what questions that you're actually asking, that you can ask, and you should be asking, is really important. And we're beginning to see the emergence of the use of realist approach in trying to understand complex interventions. So we don't want to just ask the question whether it works. We want to know how it works, for whom does it work, and you know, and under what circumstances it works. So it's really thinking about the complexity at the question stage. I think is also so important, rather than wait till you've done your search or wait till you write your protocol. By then, arguably, it can be a bit late.
The only thing I would add to that is, you know, in Cochrane, there is a big deal made out, and we're part of that, of responding to WHO. But they, you know, policymakers will often think in a very linear kind of way, and they want a particular kind of product. So I do think this thoughtful approach is also very important into feeding in, not to a recommendation, but also into how things work and how you monitor them and how you do quality improvement and assure that they are working. So I agree with you, Olivier. I think we should take this into account, not make it mechanical, keep thinking even once the review is produced on updates. So I would support that.
So I'm going to turn to Alicia. I think that, you know, one of the thoughts I had while I was listening to your presentation, you know, you talk about in some areas there's very little difference in terms of adoption of methodologies. And I wonder, because the way that we work as, you know, in evidence synthesis, we do updates. And when you update a review, you're almost tied to what you've done previously. You know, the methodology that you adopted initially, you're more inclined to be using the same approach, because if not, then you really have to redesign it and do it differently. And I mean, I would always argue that's what you should be doing at an update. You should be going back and say, well, maybe we should ask a different question rather than just bringing in the additional studies. But I wonder whether what you observed was a feature of that when people do updates, all they're doing is bringing in additional studies rather than revisiting how they've done things.
Yeah, definitely. I think that's definitely the case in the reports that I looked at. It kind of updated the reviews and then kind of included in the guideline more of like an additional report just on the studies that had been added, rather than looking at the evidence as a whole altogether again and looking back at what question we're now asking. There's definitely just a case of many of them just looked at the new studies and didn't even kind of put it in the context of the rest of the review. So.
And I think that the responsibility has to be shared between the reviewers and the guideline developers, because I've worked on very few guidelines, but my work with them has always been highly pressurized. They give you very specific questions to answer, and it's really difficult to try and push against that and ask them to think again and start again. And so I think it's not just us as reviewers and researchers who should think about that, but I think as guidelines developers should really be pausing and thinking about whether they should be asking the same question again.
I would agree with that. Can I? Sorry.
Yeah, please.
I mean, you just, WHO has been recommending mass drug administration for just about every disease in infectious disease in Africa since the 1930s, right? So, and then Melissa comes along and looks at some qualitative evidence and says, hang on a minute, nobody likes this very much. And most people spit out the pills anyway. So we sit around discussing in the review team, how are we going to feed this into WHO? It's not going to be a really popular message because it actually challenges the way guidance is being framed. And as researchers, we shouldn't be supplicants and adjuncts to this capitalist sort of production system. We should be challenging it in some ways. And so there are different ways that we can do that. And I think qualitative evidence synthesis is one way of opening up some of those questions.
Yeah, I agree. Okay, so we've got a little conversation going on in the Q&A about heterogeneity and quantitative synthesis, and I know Alex from our team has fed into this, and Miranda Compton, she has made a comment about the advice from the Cochrane Handbook on dealing with heterogeneity, and so this is about in situations where very high levels of statistical heterogeneity that have not been able to be explained despite thoughtful efforts based on a good understanding of the variation. So this is what they mean when you can't synthesize quantitatively. And it shouldn't be taken as a reason not to use quantitative methods in the presence of any level of heterogeneity. So I think that's really important point to highlight. Alex, can I put you on the spot and ask you what your thoughts are in terms of the comments on heterogeneity and how we should explore it further in terms of when do we not use quantitative methods? I know we're talking about that later on in the webinar, but just just a kind of overall comment from you would be good.
Okay, well, being a statistician, I'm probably going to be biased because I'm justifying my own existence to some degree. But yeah, I tend to think there often is something that can be done. And I think we shouldn't forget that when people use more advanced methods, people think they're making bigger assumptions or doing something more ambitious. The more advanced methods actually might be more realistically acknowledging differences between the studies and things like that. So, more advanced doesn't necessarily mean more far-flung and and speculative. I do like to think when we have quite a few studies, and hopefully I'll give an example of this later, we can try and start to look and explore the reasons for the difference. One really difficult point that is often forgot, though, is that there are really several reasons why heterogeneity might exist. And the problem is what you do about it and how you interpret the results are kind of hinging on why there is heterogeneity, and that calls for really sometimes a value judgment. I mean, if it's purely due to poor conduct of studies and is therefore essentially just all due to bias, that's very different from the studies have used distinctly different interventions or which have unique effects that haven't been taken into account. So it is a difficult area, and that's why it's been a sticking point and there's been a lot of debates for a long time. One final point, I made a comment about prediction intervals in the question and answers there, and I put a link to a paper that I think isn't read enough and the results of it aren't used enough, which is allowing you to put prediction intervals around a random effect estimate. This sounds a bit technical, but what it does is it's not just showing you the uncertainty in the average effect across the studies. It's saying if you were to roll out another study like the ones you've seen, where could the effect size be? And if there's been a lot of a heterogeneity and studies are all over the place, it tells you that any new realization of the intervention could be anywhere as well. Most people don't like that because it makes the review look inconclusive and unexciting, but actually it reflects the truth and probably gives a more honest representation of what's going on than just focusing on the mean of a random effect distribution, which will get more and more precise the more data you get, irrespective of how much heterogeneity there is. Is that okay?
Yeah, no, that's really helpful. And Debbie has just commented that, you know, this is something that she will, she has a slide on later. And so she will talk a bit more about that. So Debbie, perhaps I should come to you and ask, you know, what for a kind of a general, your general thoughts on this, you know, on the discussion so far on heterogeneity and you know how we dissect, if you like, or try and really understand the complexity of the components and the questions, and then there is this tension between, you know, whether we are able to quantitatively synthesize it, and you know, and what kind of, you know, what kind of things should we also be thinking about?
It's the topic of the talk that I'm going to give. It almost all hinges around exploring heterogeneity. And the comments in the chat have been fantastic because they feed into my talk quite well. So I wonder if it's okay to hold a little bit in suspense and to keep the mystery. Is that okay, Olivia?
That's absolutely fine. So let that be a little bit of a teaser for everybody. So we're going to come on to that at Debbie's talk. Right. Okay. So let me just see. So there's one more question about would it make sense to have an extra domain for the assessment of risk of bias of studies focusing on complex interventions relating to fidelity in particular? So what do we think about that? Paul, do you have any thoughts on that?
I'm not sure. I think, I think that studies are very different and they often give different results. And sometimes, you know, forcing a meta-analysis is what the policy people want and should be resisted. And I don't think that that's really to do with bias, but to do with context and indirectness. So in deworming, for example, yeah, obviously I get back onto my own turf and I feel better. You know, WHO was desperate to include studies from 30 years ago in small villages that were incredibly heavily infected with other studies that are more contemporary that showed no effect, in order to pull the effect to show that there was an effect, and that's how they did it for the guidelines. So I think the other point I wanted to make is sort of sensible interpretation of the studies, that sometimes it works and sometimes it doesn't, and then look at the reasons for that might be all that's needed, rather than saying like the econometrics people do here. There's huge arguments about whether you can do meta-analysis and whether it's adequately powered or not. I think just want us to keep a common sense on that. So I didn't answer the question. I'm sorry, Olivia.
No, but I think that the message is really important, that we do need a systematic framework to do what we do, but there has to be some level of flexibility in terms of how we interrogate the evidence. And especially what I'm hearing from you, and also Alicia's examples, is it's really difficult to have a rigid framework for these kind of reviews, because there are so many components, and the components itself can be complex and the interactions are complex, and not all of them can be explained quantitatively at the moment, but it's nonetheless important to try and understand that. So I don't think it's black and white, and there is no easy answer, but it's important for us to understand where the challenges are, and just be mindful and do address that, try and address that when we do our reviews, rather than group it all together and try and have a clean effect to show.
Yes.
End up being meaningless.
I actually think that the positionality of the authors is almost as important as the data in this stuff. So although Cochrane is emphasizing financial conflicts of interest, I think academic viewpoints and stances very much influence how data can be looked at. And we don't really reflect on that enough in quantitative reviews, because I think it does influence the way that they are presented and the interpretation of them. So I would encourage all teams to be thinking about what they believe is in these circumstances and how this might influence the results, because I think it can have major effects on how these complex data are managed and presented.
Yeah. Right. Okay. So I think we've come to our first break. So I want to thank my two speakers again, Alicia and Paul, for the first two sessions, and really, really nice discussions. And thank you to all those who posted comments and questions on the Q&A. So let's have a break now, and we'll come back at 2:20, and then we'll start the next two sessions then. Thank you, and I'll see you shortly.
As Debbie and Olivia have alluded to, I'm going to talk about component network meta-analysis. So rather conveniently, hopefully, my plan was to start with a recap of sort of pairwise meta-analysis and network meta-analysis. So with the pairwise meta-analysis, we have sort of two treatment options, and we are trying to answer a question that is one better than the other treatment. And sometimes a pairwise meta-analysis is considered like a lumping approach, because often when we have complex interventions, the actual interventions themselves may differ between trials. And instead of treating them all as separate interventions, we might end up lumping them together into sort of one comparator and comparing that to sort of no intervention, so that we have this situation where we're comparing any form of intervention versus no intervention. And our pairwise meta-analysis just estimates that single treatment effect estimate. Whereas in a network meta-analysis, we have the situation where we have 3 or more treatments for a specific sort of condition or disease of interest. And we're looking at comparing those treatments with each other and probably aiming to identify which maybe is the best treatment for the condition that we're studying. And this is often referred to as a splitting approach, because in this approach, if our interventions differ in terms of the components within them, then we treat each unique combination of components as a separate treatment node in our network. And so in this approach, we end up estimating a treatment effect parameter for every unique set of combination of components in the network. And as Debbie alluded to, we also need, the key assumption here is that we have a connected network. And when I come back to it in a couple of slides, I can show you an example of a connected network. So the majority of my talk is going to focus around this example of psychological preparation for adults undergoing surgery under general anaesthetic. This was initially published as a meta-analysis in the Cochrane database of systematic reviews in 2016. And they were looking at, at this point they were interested in identifying whether psychological preparation was beneficial in improving those post-operative outcomes. And I'm particularly going to focus on the outcome of length of stay in hospital, but the review itself also considers pain and negative emotions. So psychological preparation itself is a form of intervention received by patients prior to surgery in order to try and help them prepare for that surgery to then minimise their length of stay in hospital afterwards. So in this particular example, psychological preparation in most of the trials consisted of multiple components, and those components could be broken down into 6 sort of unique components of the combination. So we've got procedural information, sensory information, behavioural instruction, cognitive intervention, relaxation, and emotion-focused techniques. So in this Cochrane review, we can see in the bubble on the left-hand side here that these are some of the interventions that were included in the review, and they've all sort of been lumped together into one comparator to be compared with a control. So you can see that we've got some sort of single component interventions, and then we've got some multi-component interventions as well. So by using this approach of a pairwise meta-analysis, what they've assumed is that the effect of each component of intervention is the same. So the effect of procedural information is the same as the effect of sensory information. And that the effect of giving an intervention that consists of a single component is also the same as giving an intervention that consists of multiple components. So an alternative that they could have considered is network meta-analysis. And with network meta-analysis, we're estimating an effect size for all unique combinations of components. So for the length of stay outcome, we actually have 18 unique interventions in this network. This is the network diagram, and what you can see here is that we have this connected network because each of these interventions is directly compared with at least one other intervention in the network. And an alternative approach to network meta-analysis is component network meta-analysis. So component network meta-analysis is relevant when we have these interventions that are made up of components, often multi-component interventions. And it allows us to answer questions such as which of the components of these multi-component interventions are most effective. And it also allows us to predict the effectiveness of particular combinations of components. So for this length of stay example, the aim of the component network meta-analysis was to answer this question about which components of psychological preparation reduce that length of stay in hospital. So there are two component network meta-analysis models, the first of which is the additive effects model. So in this model, the effect of a combination of components is the sum of its parts. And if you think back to the network meta-analysis on this previous slide, here we're estimating a treatment effect for each unique combination of components. So we would estimate 18 treatment parameters here. And in a component network meta-analysis, we're estimating the effect of each component. So here we're just estimating 6 component parameters. And so because of this additive effects assumption, what this means is that if we do have an intervention that consists of both procedural and sensory information, then the effect for that combination of components is equal to the effect of the procedural information plus the effect of the sensory information. So this model doesn't allow for any synergistic or antagonistic effects that you may expect to see by giving components in combination with each other, which makes this additive effects assumption quite a strong assumption. But equally, this is the most common sort of component network meta-analysis model that is used in practice. But if we wanted to relax that assumption of additive effects, then we can fit an interaction model. Now, this includes terms that allow for interactions between pairs of components so that we can basically take into account synergistic or antagonistic effects. And this model would allow us to answer the question, are components more effective when delivered on their own or in combination? So now if we had a combination of components of procedural and sensory information, then that effect size for that combination is going to be equal to the effect of the procedural information, the effect of the sensory information, plus this interaction term, which can be estimated for giving both procedural and sensory information. Now, if that interaction term was equal to 0, then that's good evidence that the additive effects assumption is appropriate for this network, and this interaction model basically reduces down to being an additive effects model. If the interaction term is less than 0, then this gives us some evidence that there is an antagonistic effect of giving these two components together. And if the interaction term is greater than 0, then we have evidence of a synergistic effect of giving these components in combination. So I'm going to go through the results for this length of stay example. So just before I do that, just to say that there were 35 trials, including a number of multi-arm trials in this network. We had those 18 unique interventions, and we've got 6 unique components of those interventions. The outcome length of stay is analysed as a continuous outcome in terms of the number of days spent in hospital. And in the Cochrane review, they identified that any form of intervention reduced that length of stay by approximately half a day. So this is the forest plot for the 35 trials in the network. So you can see there is heterogeneity in this forest plot. And that heterogeneity may be caused by the fact that these interventions really vary quite considerably across the 35 trials. So this is the summary forest plot with the results from the additive effects model. So we've got basically the effect of each of the 6 components in the network. And we can see that behavioural instruction is the only component here with an effect size just over half a day that is sort of wholly showing a beneficial effect. It appears there may be beneficial effects for sort of 4 of the other components, but we can't exclude the possibility of a null or a negative effect. And then the emotion-focused intervention here really sort of suggests a sort of negative effect of giving that as part of combinations. So basically, if we were to use these results to try and sort of predict maybe some interventions that might be trialled in future, then we would probably recommend that they included behavioural instruction and that they avoided the emotion-focused techniques. So this slide just compares the sort of network meta-analysis with component network meta-analysis. And so the key points really are that a component network meta-analysis is only going to be suitable if your interventions do consist of components, which we know can be quite common in sort of public health examples. And some of those components do need to be common across your studies. And because we're estimating the component effects as opposed to a treatment parameter for every unique combination of interventions, it can reduce the uncertainty around our intervention effect estimates. So thinking of the length of stay example, instead of estimating 18 treatment parameters, we estimated 6 component parameters. And component network meta-analysis allows us to predict these potentially optimal combinations of intervention components, which can be particularly useful for informing future research agendas. So there are some sort of challenges and practicalities to fitting both network and component network meta-analysis, neither of which can be fitted within RevMan, which means that the sort of software options do require some knowledge, probably some programming knowledge. Both network and component network meta-analysis can be fitted in either a Bayesian or a frequentist approach. The frequentist approach can be fitted for the network meta-analysis using the R package NetMeta, and that also allows you to fit the additive effects component network meta-analysis model. But at the moment, it doesn't allow you to fit a interaction model. So if we're going down a Bayesian pathway, then WinBugs can fit all the models that I've presented today, and there is code available in the sort of public domain for fitting those models. And of course, there are other Bayesian packages such as JAGS and STAN, which are probably also able to fit these models. And in terms of the practicalities, you do need to be particularly careful when it comes to coding up multi-arm trials and your treatments or components when you're doing both standard and component network meta-analysis. So in terms of sort of further resources for learning more about component network meta-analysis, there is a Cochrane Learning Live webinar on component network meta-analysis, which was actually delivered by Debbie and Nikki Welton, and you can access that from the Cochrane Learning Live website. There's Winbug's code for conducting these component network meta-analyses for binary outcomes, continuous outcomes, and for including covariates as well. And if you do want to go down the frequentist route, then I recommend checking out the R package NetMeta. So the final slide is just my references.
Thanks, Suzanne. That's really helpful to just go through the underlying principles and the fundamental methodology for the component network meta-analysis. So we are running a little bit behind. So what I would suggest is perhaps we would do the questions and answer session at the end together after the next two talks. So if we take a 10-minute break now and if we come back at 20 minutes past, we will then start the next two talks. The next two talks is really to show you examples of these methodologies in context. So, so it follows on very nicely from what Debbie and Suzanne have said already, and then we will take questions after that. So I'll see, well, it's actually 8 minutes now, so apologies. We'll see you back at 20 minutes past. Right, okay, welcome back and thanks for staying with us. Apologies again for the technical challenges. Unfortunately, which it is beyond our control. So thanks for bearing with us. So now I'm going to hand over to my colleagues, Dr. Terry Quinn and Dr. Jenny Burton. They're going to do a double act. They're going to share with you their experience on the delirium prevention review, where they have to explore the multiple components of the interventions. So they're going to share their journey with us. I'll hand over to you, Terry and Jenny.
Thanks, Olivia. Let me just get my screen ready. Bear with me a second. Okay, so if someone could give me a thumbs up just to say that they're seeing something that looks like a slide.
It's good. Perfect.
Okay, so thanks again, Olivia, and thanks for inviting us to share with you the experience that we've had with multi-component interventions. So you're getting a tag team for this short talk. I'm Terry Quinn. I'm the coordinating editor of the Cochrane Dementia Group, and I'm an academic in Glasgow, and I'm going to give you a little bit of context. And then the person that did actually all the hard work on this review, Jenny Burton, who also works in Glasgow, will tell you a little bit about her experiences of trying to look at multi-component reviews within the Cochrane context. So the review that we were working with was a review looking at this clinical syndrome of delirium, of acute confusion, which is something that we see all the time. It's something that's very well known to clinicians, but actually historically didn't attract a lot of research interest. And that's something that's sort of changed in the last 10 years or so. And although our Cochrane group is called Cochrane Dementia, we very much consider delirium to also be part of our remit. So I mentioned that it's only really in the last few years that delirium research has sort of gained visibility, but that doesn't mean that delirium is a new concept. It certainly isn't. Just to give you a little bit of a background to this, delirium has been recognised by clinicians for thousands of years. You can see here descriptions from two very prominent early physicians describing this syndrome of people who become confused when they're unwell, there's disturbance of consciousness, and it sometimes doesn't get better. Is this a public health concern? Well, I think it probably is, and that's for two reasons. One is delirium's very common, and wherever you look for it, you find it. If you look in a general medical ward, it's about 40% of people, and if you move to critical care settings, it's even more. Actually, in the intensive care unit, delirium is almost the norm. But that's not to say it's a benign thing. If you look at what happens to people that have delirium compared to people that have a similar illness and don't have delirium, bad things happen. Mortality is increased. Rates of admission to care home are dramatically increased. Functional decline is increased. And dementia following delirium is absolutely huge. Delirium is one of the major risk factors for for incident dementia. So hopefully I've convinced you that this is an important thing. And in Cochrane dementia, we certainly thought that delirium was an important thing, and we've developed a suite of different reviews looking at delirium. And we've sort of divided them up in different ways. We've got reviews looking at the treatment of delirium once it's established. And some of those reviews looked at drug treatment, some of them looked at non-drug treatment. And we've got reviews looking at how we try and prevent delirium from happening in the first place. And again, we've got drug reviews and non-drug reviews. And those, those reviews have been useful. If I can summarize them in maybe 1 or 2 slides, I can tell you the treatment just doesn't seem to work. All of the different drug and non-drug therapies that have been tried for once someone has delirium just don't seem to deliver. So probably prevention where you want to put all of your energy. And even in prevention, what we found was that drug-based preventive studies, when we reviewed them, they didn't seem to work. So the big return was in non-pharmacological prevention of delirium. And that's a thing that's actually been recognised for a long time, since the late 90s, when the Hospital Elder Life programme began, which did things that you might think of as rather basic, ensuring people didn't get dehydrated, ensuring people had their glasses on, ensuring people had hearing aids in, getting people up out of bed. Very basic possibly, but effective. And that help programme substantially reduced the number of people that developed delirium when they were admitted to hospital with illness. And if you look here, you can see that essentially what help is it's a multi-component intervention, lots of different things, all used together to try and prevent delirium, and they work. So a few years ago, we reviewed these multi-component interventions. In fact, we reviewed any non-drug intervention for preventing delirium, and this was that review. You can see Jenny was one of the authors on this. And unlike a lot of Cochrane dementia reviews, we were actually able to make some recommendations, because we were able to say that there was very strong evidence that multi-component interventions could prevent delirium in hospitalised patients. And I have to be honest with you, not many of our Cochrane dementia reviews are able to say something as robust as that. So we're very pleased with this review, and it's been an important review for us. Certainly it's one of our most downloaded and cited reviews. When we get our annual returns, it's always in our top 10 or top 5. And it also made a big impact on social media. It's one of our Cochrane reviews that has the highest altmetric impact factor. And perhaps more importantly than all of those things, it's a review that's had an impact on policy. So partly driven by that review, the SIGN Guideline Network in the UK and Scotland initiated a guideline on delirium, and the review formed a big part of the evidence that they drew on for that guideline. So that's where we were, and we were very happy, but the review didn't really answer the questions that clinicians and people setting up services wanted to answer. So what we had shown was, if you take a group of older adults in hospital and you do a multi-component intervention, it seems to prevent delirium. But what we hadn't shown was what that multi-component intervention should be. It was the classical black box. It works, but we hadn't defined what the ingredients were. And you can look to see what recommendations are for multi-component interventions. So here are some recommendations from NICE. And it's things like, again, making sure people aren't dehydrated, attending to their bladder and their bowels. But other people had different recommendations. So this is from a synthesis of mostly observational studies. And you can see that this list isn't quite the same as the list that came from NICE, which in turn wasn't quite the same as some of the other lists of things that we should be doing as a delirium intervention. So that's where we were. We knew that new trials looking at delirium prevention were coming out. So although that initial Cochrane review was only a few years old, we felt we wanted to do a fairly rapid update of it, but not just update, we wanted to do more, and we wanted to see if there was any quantitative way that we could look to try and unpack the black box of what those multi-component interventions were. So hopefully I've gave you some context. And I'm now going to hand over to Jenny, who's going to tell you a little bit about the process of that review and how we unpack the box.
Okay, thanks, Terry. So I guess just to orientate everyone to the analysis. So our population of interest were hospitalised adults who weren't looked after in critical care settings, so those in just general wards. The intervention was this black box of non-pharmacological multi-component interventions, and they were all being compared to usual care. The outcome that we were interested in was the incidence of delirium, so the number of people who go on to develop delirium diagnosed with recognised tools while they're an inpatient in hospital. And the headline results of the updated review were great. So using appropriate Cochrane terminology, we had moderate certainty evidence that we could reduce the incidence of delirium by 43% compared to usual care. So again, consistent with the findings of the previous review, and if anything, strengthened with the addition of the new studies. However, as Terry said, one of the biggest problems that we have, and that I find whenever I present this data to my fellow clinicians, is they go, well, that's fine, but what does that really mean? What do I need to do, and what do I need to make sure happens to my patients to achieve these phenomenal results that you keep telling me about? And so with great input and thanks to Suzanne, who you've heard from, and Alex, who you will hear from, and their methods expertise, we were able to sort of take that together and work as a combined team, sharing our expertise to try and look at those factors. And I think one of the key things, obviously, in trying to deal with all of the studies that we found was that this sort of shared collaborative approach was really, really helpful to make sure that the decisions that we were making about lumping and splitting and how to categorise things were things that would be coherent and consistent with clinical practice, so that at the end result, what we've done with the data has that sort of salience and meaning, as well as being methodologically appropriate. So next slide, please, Terry. So this is the table in Cochrane format from the original review, and I guess it's just to show you where we started from. So we had 7 trials that included between 2 and 12 components each. But when we did this kind of mapping exercise the first time round, we found there were about 20 different things, ways of describing and categorising what had been done in those studies. And so it really wasn't very clear at all what your critical factors were to say that the intervention would be successful, and what should you do to reduce delirium. Fortunately, our update search, which as Terry said was just 4 years further on than the original, found 7 new trials, so gave us the opportunity to really look at this and deepen our understanding. So on to the next one, please. So we took forward that structure, because I guess when you've already got somewhere to begin, you don't start making it up from scratch. But what we did was another process by which we looked at all of our 14 studies, and 2 of us independently sat down and extracted the text where the intervention was described, which obviously varies in length and detail depending on the original study, and tried to say, well, what are the components that they are describing and how can we classify them? We started out, as I say, mapping them into that framework, but then had to do something, because with 14 trials and possibly 20 different constructs, that wasn't something that was going to work methodologically. And actually, it needed a bit more thought, because to be honest, to map the components the first time round was really just to highlight that heterogeneity in components, whereas this time we really wanted to do something with them. So I guess the simplest thing we did was to exclude a component where we could only find it identified with the 14 trials in a single study. So that was a fairly non-contentious thing to do. In other cases, we looked at how we could combine categories. So this again was where we were combining our sort of clinical approach, but also looking at where things were delivered together. So there was an item about managing an individual's electrolyte balance, which we felt went consistently with attending to nutrition and hydration. And they were only found, so the electrolyte balance one was only found in studies that also did nutrition and hydration. So we created a category that brought them together. Similarly, there was a category about use of familiar objects, so bringing in photographs or clocks or items from home. And there was another one about reorientating an individual. And familiar objects was only used a few times, but again, always with reorientation. And again, we felt you could put those together and say, actually, these are all about trying to bring that person into the moment so that they know where they are and they don't think, oh gosh, I'm in this empty cell of a room in hospital, what's going on for me? So those seemed reasonable to combine. I guess perhaps more contentious or more up for debate is that we then found a whole series of components or characteristics that are about how the intervention was delivered. And this included whether they used checklists, there was an educational component, involved the multidisciplinary team. And I think in the end, what we decided was that actually how the intervention was delivered was distinct enough from the components that the intervention had to have, that what we did was we uncategorized them as components, and so didn't treat them as components for the analysis, but made sure in our reporting that we noted how they were delivered, and then used that to say, actually, these are things that need further input and review, and you could argue potentially lend themselves to a different both method of research evaluation and sort of implementation into practice of, well, how do I most effectively deliver this component and how is that done? I think what I'd say at that point is we recognise that there are multiple ways of doing this, and a different group of authors might have come up with a different approach to categorising the components. But I think this felt for us like something that retained a clinical salience that separated out intervention delivery from the components of the intervention, and of course, importantly, allowed the model to fit. So on to the next slide then, Terry. So we took 12 components forward into the analysis, and very much for our review, this was an exploratory analysis to see what was going to be possible. And actually, helpfully, what we found is something that again holds true and feels quite clinically meaningful, that reorientating people using cognitive stimulation and sleep hygiene were associated with a reduced risk of incidence of delirium. We then identified other factors where estimates included the possibility of no benefit or harm, and others where there was a suggestion that delirium was potentially increased, but there was uncertainty in those estimates. And I guess, well, some of those you maybe think, oh, maybe, but then I guess highlighting one in particular that's quite clinically coherent is pain control. So yes, we know that pain is a risk factor for delirium, but we also know that a lot of the drugs that we use to treat pain can contribute to delirium, and clearly there's a balance to be struck for the individual person. But it doesn't strike us, and again, as a group of clinicians, that pain control would necessarily be something that would universally prevent you from having delirium, because actually it may contribute to that being more clinically common. So last slide for me. So the full review is online, and we obviously chart out both how we got to where we got to, and the process that we followed, really reflecting back on how the interventions were reported in the studies, and what we've included and excluded and how we've categorised things. And clearly this isn't the end for understanding multi-component interventions in delirium, but I think it does move us forward and is a useful advancement to show what can be achieved, both from using the existing data that we have, so this contemporaneous update of 14 trials, using these new methodological approaches, but also hopefully allows us to direct a bit the future of the next research studies in terms of what they're focusing on, and really puts the emphasis on both the reporting of components and making sure that that's really nice and clear and allows these kind of analyses to take place, but also lets people drill into some of those ones where there's a bit more uncertainty and a bit more evidence required. So I think it does take us to a slightly more meaningful, more research is required recommendation at the end of the review. Thanks.
Yeah, so it's been a journey for us as a review group. I think if we just look at the author list here and echo something that Jenny said, I think why this worked and the way we got this to work was that marriage of people that had the methodological and the statistical expertise, and then people like Jenny that could make some clinical sense of it as well. And I think if we didn't have the two working together, we probably wouldn't have been able to complete this analysis and give something that that had a face validity. So already, although this review has only been out a few weeks, it's already, it's already making an impact. We successfully applied to get incentive award funding to let us finish the review back in the day when NIHR funded Cochrane reviews, he said controversially. It's a review that's been picked up by lots of people. You can look at our little altmetric map here, and you can see how often it's being discussed in social media, on blogs and tweets, even in news outlets. So, it's clearly an area where people were looking for this review, and it's being picked up in meetings and discussed, not only discussed in terms of the review findings, but also in terms of some of the other things Jenny said about what future trials should look like and how they could perhaps better report the components of their multi-component intervention, so that when we come to do this review again, it's easier for us to try and bring things together into a synthesis. So there you have it. The purpose of this short talk was really just to show you can do multi-component analysis within the Cochrane framework. We think it's been very useful for our group. We think it's been a review that's going to be useful for clinicians, but also for policy. And we're happy to hear questions and to hear your thoughts. And Jenny and I can answer any questions you have specifically about trying to do this kind of thing within the template of a Cochrane review. So I will stop sharing there and hand back to Olivia.
Thanks, Terry and Jenny. And yes, it'll be really good to hear from especially Cochrane reviewers what they think the challenges might be. I think it's a really good example that pulls together everything that has been said so far in this webinar. It really points to what Paul was saying earlier about really working together to understand what's important. So here you've highlighted what's important to the clinicians and to the patients, and then the methodologies that both Debbie and Suzanne was talking about, and you've demonstrated really nicely here. So before we go to our final remarks and comments, I'm going to ask my colleague Alex Sutton to give the final talk. Alex is going to show us a separate example. I think this is also a Cochrane review on smoking cessation. This is something that Alex have worked alongside Cochrane reviewers in our support work, I think. So Alex, I'll hand over to you.
Okay, thank you, Olivia. I think people can see and hear me.
Yes.
Thank you. Yeah, exactly as you said, this is really, I just wanted to talk briefly about another case study because, again, it was another interesting one, I think, like the one that Terry and Jenny have just talked about and got some interesting results. It's on a very different scale, and I think that's why it's a bit of a contrast. So we're looking at behavioural interventions for smoking cessation. And again, this is a Cochrane review. There is the front page of it. And again, I'm making it very clear, Suzanne and I gave advice. A lot of other people did hard work here. Jamie Hartman-Boyce leads the group. Jose is the statistician. I think Jonathan, I think you might be on the call today. And if you've got anything to add, please do so in discussions. So the objective was to conduct a component network meta-analysis to determine how modes of delivery, person delivering the intervention, and the nature, focus, and intensity of the behavioural interventions for smoking cessation influence the likelihood of achieving abstinence 6 months after attempting to stop smoking, and whether the effects of behavioural interventions depend upon other characteristics, including population, setting, and the provision of pharmacotherapy. So that's an exact and precise way of really saying, looking at not exactly as Terry said, this isn't as black box, trying to unpick the black box and out of these multiple components, which of those are working best and do they work differently for different groups of people? Just before we move on, I just want to say as well that before the CRSU was open for business and we started collaborating and giving advice to groups on reviews, I hadn't predicted that these component models would be necessarily that popular or relevant, but it seems to be just about the most commonly used model that we've helped and supported over the last few years, which has been an eye-opener. And I think it is relevant. Just if we go back to what Alicia said earlier on, there's a lot of interesting and difficult questions that are yet to be answered that are about complex interventions. And I think, again, this is quite a different context from the one Terry and Jenny were talking about, but again, an interesting one and not a million miles away from public health. So one thing that's slightly different here is that what really this is really a formal quantitative synthesis as a review of reviews or an overview. So the team looked at previous Cochrane reviews to identify the trials and just looked at trials that compared either behavioural interventions or with other behavioural interventions or with no interventions for stopping smoking. It had to be adult and measure smoking abstinence at 6 months or longer. And it turned out, again, a similar kind of process. It's not sometimes immediately obvious what the components should be or exactly how they're defined. They came to a list of 38 components, so quite a large number compared to minimal interventions. And these included behavioural, motivational, intervention providers, delivery modes, nature, focus, and intensity of behavioural interventions. And we also added in there covariates to evaluate the influence of population characteristics, provision of pharmacotherapy, and intervention intensity in the component effects. So these are things that aren't necessarily about the intervention itself, but may influence how well the intervention works. And this is the bit the group should be proud of. So looking at 33 reviews, identifying 312 trials representing 250,000 participants and 845 distinct study arms, looking at 437 different combinations of components. And I just want to take a minute here to sort of relate what we've been talking to. As I've been listening to the others, I've been thinking about the old chestnut in meta-analysis, which is, you know, this lumping versus splitting. And what do? Do you keep your inclusion criteria narrow and answer targeted questions? You broaden it out at the danger, you include more information, but at the danger of the question being less precise, targeted, and sort of you're answering a blunt question. In a sense, I'm hoping that with this sort of modeling, you kind of can have your cake and eat it a little bit, because what we're trying to do here is look at an overview across a very broad range of evidence, but we're not just lumping it all together. We're trying to use a big population with a lot of power and then try and differentiate between studies and explain why studies have different estimates. And I think there's generally a growing trend to do this in evidence synthesis for the use of standard network meta-analysis that Debbie was talking about, where these methods seem to answer the questions that are most clinically relevant. It's not, is treatment A better than treatment B, or is component A better than component B? It's what's the most optimal treatment for this condition, or does the optimal treatment vary with patient characteristics, or what is the most optimal or cost-effective combination of components? So I think they kind of fit well to some of the questions we try and answer. And while you can use less sophisticated measures and methods to answer targeted questions, they may be less clinically applicable. You know, is treatment A better than treatment B? Then next review, is treatment B better than treatment D? And is D better than C, etc. Or splitting things off. And I think it's nice to see a sort of coming together of previous reviews to have a look at all the information together, if you like, and that's what's happening here. I'm not going to go into the huge details on the modeling, and Jose did a lot of that, and there were challenges because of such a large data set and a large number of models to fit. I'm just showing you the results here, the very top line results, which shows you the impact and effect of all the different components, those 30, I think it was 30 odd, or wasn't I mentioned on the previous slide. And the bold headings, if you can work them out here, are the different types of component. So can we pick some out here? how it affects behavior, the behavioral ones. There's one that's a very strong effect. Where is it? It's when you're given financial incentives. Oh, this isn't very professional, is it? Fine. You will be shouting at the screen. There it is, financial incentives, big effect. Other ones here are the delivery, and that these obviously have changed over time a lot with emails, texts, audio, or whatever, face to face, and looking the most effective with the electronic ones looking pretty good at the in the effectiveness there. But I'm not here to talk about the specific results of this review, other than to sort of note that, you know, this is a top view. You can get distinct estimates of all these components. You can then estimate the combined effect of any of these components, and more work's going on to looking in more detail at that. Yeah, just pointing a few things here. I'm not, you know, I don't think anyone that was involved in this work is necessarily saying this is the final word in this analyzing this data, or the final word in component modeling. There's certain things we all, one thing that we questioned was, you know, are the effects additive? Should we include interactions so they can be synergistic or antagonistic? Do you have like what we call gone blank, come back to me, where you, the more components you had, maybe they get less effective, sort of decrease, the opposite of economies of scale, sort of decreasing added benefits as you get more components. I always find study quality a difficult thing to deal with. Yeah, diminishing returns, that was the phrase my brain went blank on there. And yet study quality is something that I always find very difficult to deal with, and I can say a bit more about that if you have questions on that. And, you know, the word points that were identified in this big cloud of data is very much outlying from the rest of it, and it was interesting to flag those. And yes, the component definitions is a difficult area, and I think this goes right back to Paul at the beginning and talking about, you know, this isn't a procedure, a turn the handle sort of procedure, follow step 1 then 2, that you've got to kind of engage brain and engage the experts in the area. Was certainly true here, and maybe a bit of iteration. You know, I'm not against, I know other people may disagree with me, I'm not against iteration and revision of protocols for systematic reviews and meta-analysis as a result of the information you find. We're still not sure how to assess publication bias in this sort of data very easily, and that's certainly something for further work. And as I've said, that we are looking at this data in more detail, looking at combinations of components, trying to identify promising combinations that may never have been tried before, to say, well, perhaps it would be worth doing trials in these things to see if they do get really as good effects as you might predict. Oh, sorry, that was the end of my talk. That was an extra slide that we can talk about if required, but I'll leave it there. Okay, thank you, Olivia.
Thanks, Alex. So that's a really nice example of what you can potentially do when you have an enormous amount of data. And hats off to the team for actually, you know, extracting and you know, getting hold of data is difficult, and extracting it, and, you know, for the analysis. So I'd like to go to questions before we go to reflections. And Miranda has asked a very good question. And as I was thinking, I really want to reiterate that, you know, we talk a lot about component network meta-analysis today, but this is not the only approach, and this is not, by no means are we saying this is the best approach. But what we find is a very useful tool in a lot of circumstances, and because we have done a lot of support work using this methodology, that's why we thought we should shine a light on it. And Miranda quite rightly asked, what are the panel's thoughts on how component network meta-analysis compares and contrasts to other approaches such as meta-regression or qualitative comparative analysis, or, you know, or any other analysis that we potentially can use? So I'm going to go in reverse order. Alex, I'll come to you first. What are your thoughts on the different approaches?
Yeah, that's a good question, isn't it? Because we should get this clear in our heads, and it would be helpful. I really see that these things, I'm going to leave qualitative a bit, and hopefully somebody else can deal with that. If we think about, I can't remember if somebody put a slide up earlier, we can actually say that if you kind of don't model components and treat each combination of components as its unique treatment that just, you know, may have components A, B, and C in one trial and B, D, E in another, or whatever. If we just keep those combinations of components as unique treatments to be estimated, you get to network meta-analysis without components, you know, and I think that's helpful to think about. The problem with that is you can have, you know, like in that smoking one, you've almost got nearly as many combinations as you have studies, or as many. So the power goes. So in some ways, we're making a slightly stronger assumption to assume some sort of additive, in at least in the first instance, effect of components, versus assuming that the effect of combinations of components is always unique. So we're kind of appealing to some sort of additivity there, but we can add interactions to relax that. Meta-regression in my head is a way of saying the treatments usually are, one or more of the treatments isn't constant. Something affects how the treatment works, how effective it is. And therefore, we're trying to say there are some treatment interactions, if you like, in the model. And I think usually meta-regression is ways of adding covariates in to deal with that. And that can be done in a pairwise meta-analysis. It can be done in standard network meta-analysis, or it can be done in component network meta-analysis. It's kind of that other dimension that can be brought into all three, and probably should be if you think treatment effects are varying. And indeed, this is all going back to trying to explain the heterogeneity and what we see variability between treatment effects beyond what we'd expect. Can we explain it?
Okay, thanks. And Debbie, are you still on the call? Because I think it would be good to hear what your thoughts are on the different methods. I think you touched on that briefly with.
Yeah, I'm still here, Olivia. So I think I agree with everything Alex said. But thinking more about the kind of the qualitative side of things, I think and actually I think Paul mentioned this in terms of how you're identifying the components in the first instance, that there are different approaches that you can take to do that, and very often it's the qualitative studies that are sometimes done alongside process evaluations, for example, that happen alongside the more quantitative outcome evaluations of complex interventions, that can provide some of the richness of the detail about the interventions themselves that enable us to do these component analyses. And it might sound a little trite to say it, but I think often when we're talking about mixed methods, we're actually talking about somebody did a quantitative analysis, and then alongside it, they looked at some qualitative data, and they don't, that they're not integrated or weaved into each other, drawing on the strengths of each other. But in a way, I think that's what we're doing with a component network meta-analysis. And indeed, some of the methods we use to identify the components are qualitative. So if you're reading your paper, trying to look at what components were used, the constant comparative method is one approach to coding up the components. So I think there's the potential that it's the most genuine mixed methods approach that we might have in systematic reviews. That's potentially controversial more than it is trite, but there you go.
Okay, Paul, what's your thoughts on this?
This has fascinated me, this talk. I mean, I think the component meta-analysis is a very powerful tool that can raise hypotheses that may well help you in designing programs and taking them forward. But I do think qualitative research around how the interventions are delivered is really quite important. I mean, you can't capture trust between the provider and the patients in a component meta-analysis. I'm not sure how you can provide it anyway, but this can be a very strong effectiveness component, a very strong determinant effectiveness of mental health interventions or dealing with chronic fatigue, for example. So I think this is, it's a long way forward, but I do think there's a way of integrating these results rather than using qualitative research more innovatively in the future, rather than it always being a bit of a tack on how best to deliver these programs that are determined by quantitative methods.
I must confess, as somebody who sits on NIHR funding panel, and this is something that I do pick out when people propose to do qualitative and quantitative synthesis. There's this disconnect that Debbie was talking about. They do it in parallel, but they don't bring it together. So you end up with two distinct pieces of information that doesn't really help you make a decision because they don't speak to each other. And I think there is so important to try and think of ways to bring it together. Terry and Jenny, I mean, I get the sense, with your examples, Jenny talked about, you present this to the clinicians and they're saying, well, what does it mean? What should we be doing? So in a sense, there is this qualitative component of, forcing you to sit down to think about what are the components that are relevant and important. So from somebody who's done a review under the Cochrane framework, thinking about using these methodologies, different approaches, what are your thoughts?
Yeah, well, I guess the one of the reasons we chose to do this was it was motivated by the feedback that we'd had from clinicians, and from people who had seen a guideline recommendation that said use multi-component interventions, and they quite rightly said, well, what does that mean? And I think, it's something that we've spoke about before in other webinars. I think the best reviews come from that clinical space of people saying, this is a question that we need an answer to. And what we did, Jenny and I, was we came to CRSU. We kind of gave the remit of what we wanted to do. We explained it theoretically. We thought that the components may have interactions. We didn't think it'd be just existing as single components. We explained that there weren't going to be lots and lots of trials, so there were going to be limits on what we could do with the analysis, and we came to where we were with the way that we decided to analyse things. For your comments about combining the quantitative with the qualitative, even with our review, there's still a lot that needs to be answered about, well, how do you implement these multi-component interventions? How are they perceived by staff? How are they perceived by those people that you are using them with? So I think that there's huge scope to then add qualitative aspects to further studies in this area.
Thanks, Terry. Right, I'm very mindful of time, and I just want to say Lisa Barrow was supposed to give us some reflections at the end. I'm going to ask Paul if he could give some reflections on, from a Cochrane reviewer's perspective in terms of what we talked about. Just very briefly, Paul, I must apologize, we were slightly overrun, so it would be good to hear voice on behalf of Cochrane, if you like.
Okay, so Olivier, thank you. And I mean, it'll just take a minute and a half or something. For me, this seminar told a story. So I compliment you and the team for taking us through and telling a story with the whole day. And we've also had all the buttons like fixed versus random, lumping and splitting, and network meta-analysis. So you can't get much better than having all those debates thrown in there. So thank you very much for that. I think Alicia, started out talking about complex interventions, a poorly described variety of settings, and these multiple interaction components and started highlighting the problems. And I sort of could see from in my global health area the need to describe inputs and to do this in an iterative way, which and pointed out how policymakers can get misled by not understanding complexity. And Debbie took us on to this, that heterogeneity is inevitable, and started introducing that network meta-analysis may help, and that's how the story unfolded, with components being able to help dissect out these effects, both with the psychological interventions and talking about additive and synergistic and so on, which was really helpful. And Terry and Joni added a further sort of dimension to that with delirium by adding in the using clinicians as well to help shape how the data, how the analysis, the component meta-analysis was taken forward. And I found it fascinating that they had 2 rounds of mapping, and one which was around components and methods of delivery. One was about components and one was about methods of delivery. So I learned from that. So, and Alex's Sutton was, as always, incredibly elegant and large, and a meta-analysis of meta-analysis, if you see what I mean, with 33 trials in there. It was absolutely awesome. I learned about these new methods in network meta-analysis, how clinicians and methodologists need to work together. An indication, it helps understand the important components in complex interventions, with possibility in the future of proper transdisciplinary approaches that include clinicians, patient views, and qualitative research in this process.
Thanks, Paul. So I just want to bring this webinar to a close. Apologies for overrunning and apologies for the technical challenges, but I want to really thank all the speakers, my colleagues and friends of CRSU, for making this a really, really interesting and useful webinar, and I hope you feel the same. And we look forward to doing this again. We hope we can do this in person sometime rather than do this by Zoom, because it can be very challenging, as you can all see. So as I said, the recording will be on the CRSU website, and if you have any questions on these topics or just broadly anything to do with complex reviews, just drop us an email at the CRSU. We're always happy to chat to reviewers and get to know what reviews you're doing, and just try and help you navigate this knotty issue of complex interventions. There's no right or wrong answer. We might not know the answer to some of your questions, but we're really interested in supporting you and helping you explore all the challenges. So thank you again, and hope to see you all soon. Bye.